Coming to you from the Forge of Freedom studio in the heart of America, a podcast dedicated to preserving freedom and inspiring personal success. Freedom is born and lives through you, the individual, and it dies in the shadows of tyranny. Motivating our listeners to become well-rounded, freedom-minded people with the body of an athlete, the mind of a stoic, and the spirit of a warrior. The tree of liberty lives on through you, the Forge of Freedom. And now here's your host, Alex Ooley.
Hello, everyone, and welcome to another edition of the Forge of Freedom podcast. I'm your host, Alex Ooley, and this is episode 38 of the Forge of Freedom. Today, I have my wife, Whitney, with me to discuss a class that we recently took in Zanesville, Ohio, with Greg Ellifritz. It's called Tactical First Aid and System Collapse Medicine. So first of all, welcome to the show, Whitney.
Yeah, thanks for having me.
For those of you who don't know Whitney, she is a physician assistant, and she works at an urgent care here in Southern Indiana. She was also recently on episode 34 with a few friends about the Homestead Festival at Hardison Mill in Columbia, Tennessee. And I've got her back on the show today to talk about the class that we took with Greg Ellifritz, the Tactical First Aid and System Collapse Medicine. And for those of you who don't know Greg Ellifritz, he's the man behind the Active Response Training website, which is a great website. It's really incredible how much information he's accumulated on that website over the years. And one of his best resources, and I'll link to a few of these in the show notes, is the weekly knowledge dump, the weekend knowledge dump that he provides every week. But we took this class last weekend in Zanesville, Ohio. And I think, at least for me, it's an interesting class to take just because, I don't know, the content is interesting. Greg Ellifritz is interesting in the way he presents it. But this is also, I think, really important information to know because, as you know, I'm a firearms instructor and we focus a lot of times on the gun, but we're far more likely to need first aid skills than our gun because we're far more likely to come upon a wreck or someone who's injured or suffering from some sort of cardiac event than we are to need to use deadly force in our self-defense. So anyway, we just wanted to share a little bit about the class, kind of do a little review. We're not going to get down into the weeds of all the things that we learned because this was an all-day class.
It was.
So then we could take a long time on the podcast here.
And Greg might not like if we share all his secrets.
He does have, I will mention, and I'll mention this again at the end, hopefully, if I remember, he does have this class, if you're interested in taking it, I think 2 more times this year. And I don't have it in front of me. He has it one more time in Ohio and one more time in North Carolina. And I'll link to that in the show notes as well. So if you listen to this podcast and you're interested in taking the class, be sure to check out the show notes for that information. So I guess to start out a little bit, Whitney, a few months ago when we talked about taking this class, you agreed to take it, but you've got quite a bit of medical education as a physician assistant, right? I mean, you had to get a graduate degree,
right?
And nevertheless, you wanted to take this class. You want to say just a little bit about that? Why?
Sure,
what motivated you to tag along with me on this class?
Yeah. So I work in urgent care, so I see medical patients and situations almost on a daily basis, but I see minor injuries and minor wounds. In the urgent care setting, at times we have cardiac events come in, or people in respiratory distress, but it's in a sterile environment. We take care of them. We call EMS and they transport them to the ER. And we were talking about this, and I've watched YouTube videos about using a tourniquet, things like that, but I had no deep knowledge about packing wounds and massive bleeding. And in PA school, that just wasn't a thing that we covered. We may have had 30 minutes on it, but we didn't practice with tourniquets. We didn't do needle decompressions for a tension pneumothorax. So I know that's kind of scary and sad to say, but I didn't have training, in this area. And I think for me personally, thinking I'm a medical professional, and if I came upon a car wreck, or God forbid there was a shooting or something that I would need to use my skills, I didn't have the skills to be helpful in that situation. So I wanted that to change.
Yeah. Well, and you said it's maybe sad that you don't get this sort of training in physician assistant school, but I kind of compare it, and I've said this on numerous podcasts, that in law school, we learned almost nothing about the Second Amendment.
Yeah.
And, that's what I talk about more than anything when it comes to the Constitution. And, well, I don't know about more than anything now, but that's a lot of what I talk about is the Second Amendment. But certainly, even if you did learn a little bit about treating traumatic injuries, it certainly wasn't in the context of a non-sterile environment. Right.
I mean, it would have been, this is what happens in the emergency department when you do this, or like a trauma center.
Yeah. Or what do you do when you don't have at your disposal certain medical tools, or medications or drugs? How do you improvise and try to save somebody's life by
getting creative? How do you do that? I mean, we just didn't discuss that.
Yeah, and that's a lot of what this class is about, right? Is the class is taught primarily from the perspective of what's called the tactical combat casualty care protocol. But the other thing that was interesting, which was developed to try to prevent battlefield deaths, right, from traumatic injuries on the battlefield. And that was the primary perspective of this class, is teaching those skills, those protocols. But the other thing that was interesting too was that, and this is applicable to you and I, and I think is partly why it was of interest to us, is that he sort of contrasted that approach, the battlefield approach, the tactical combat casualty care approach, with a wilderness perspective, because those aren't always the same either. What resources and tools are maybe available to a soldier in combat would be different maybe than what's available to somebody who's maybe hiking the Appalachian Trail or hiking the Grand Canyon, like we've done. So that contrast I thought was interesting too. Would you agree with that?
Yeah. And I think that's another point, we forget about, is being avid hikers. Things can happen. You can misstep, and it could get hairy real quickly. So I think it's important to know all of this for ourselves and for others around us. Yeah.
And for those who don't know too, I've got this in my notes here. The tactical combat casualty care protocol is the only, and I didn't know this before the class, but it's the only standard of care that's duly endorsed by the American College of Surgeons and the National Association of EMTs for Casualty Management. So, I mean, EMTs, right, are a lot like police officers, is that they can't always be there and they can't be everywhere all the time. And when seconds count, we always say police are minutes away. It's sort of the same thing with EMTs, right?
Definitely.
So if you are equipped, if your family, your friends are equipped with these skills, you can save valuable seconds in administering immediate care or nearly immediate care that are valuable seconds that could save somebody's life. Right.
Yeah. I mean, I may be getting ahead of ourselves, but someone can bleed out in 2 minutes. Well, if you live like somewhere we do, your ambulance is not going to get there in 2 minutes. And if something happened and they're bleeding out, they could bleed out before the ambulance got there.
Yeah.
So.
Yeah, I think, and this is important too, the principal mandate of the tactical combat casualty care protocol is the execution of the right interventions at the right time.
Right.
Because especially in a battlefield situation or in a situation where there's a bombing, you think about the Boston Marathon bombing, or a massacre with a firearm in a movie theater like we saw in Aurora, Colorado. You can provide good medicine, but if it's not at the right time, if it's not immediate, that can cost lives. And we know that people who are trained in this protocol can prevent upward of 90% of battlefield deaths, right? If they administer these skills and protocols in a timely manner. Yeah. So with that in mind, actually, if it's okay, I think I'd like to just use the example of why people might want to know these skills. We've talked a little bit about it in terms of, you might come up on a car accident. You might come up on a situation where there's been a mass killing of some sort with either a knife or a shooting with a firearm. And I mentioned the movie theater example in Aurora, Colorado. The killer there came in with 3 different firearms. He came in with a shotgun and emptied it. He shot his rifle until it jammed. And then he finished with a handgun. And many of the people there at the theater thought that there were multiple shooters because he brought in multiple firearms. But there was a situation where, and this is just, again, an example of you're not going to be performing these skills in a sterile environment like a hospital or an urgent care or an emergency room. This is going to be an environment where there's chaos. This guy, he threw smoke bombs to create confusion and chaos. And you're going to have to make decisions, critical decisions in valuable seconds about how to get to safety, number one, and number two, what sorts of care to administer and who to administer it to.
Who to help first.
Yeah. One example that Greg Ellifritz used was from the Boston Marathon bombing. You want to talk a little bit about that, how you sort of had to prioritize who to provide treatment to?
Yeah. I mean, it's almost like you would have to do a quick triage of when you look around. And he showed us a picture, and there was a lady who was sitting. She looked stable, so you would leave her be and, just kind of monitor and keep a close eye on her. There was unfortunately 2 people who were laying there, possibly deceased, possibly unconscious, and then there were 2 actively bleeding leg wounds. And he asked, who would you help? And you would help the leg wounds that were, have massive bleeding because they're conscious and they need medical care right now.
Yeah, because we had somebody who appeared to be okay, at least not in need of emergent care.
Right.
We had 2 people who appeared to be already deceased or nearly deceased. And then 2 people who were clearly alive and conscious, but suffering from massive bleeding. And it could
take a turn very quickly for them.
Very quickly. And there's something you could do about it. Right. So I think that's a good segue then to get into the tactical combat care, casualty combat care protocol. And it starts with this acronym, right? The MARCH acronym. You want to talk a little bit about that? What's the M to begin with?
So the M is for massive bleeding. So an interesting statistic he gave us was about massive bleeding is that applying direct pressure can stop 95% of bleeding. But of course you can use tourniquets, you can use dressings, you can use packing. All of those things can stop massive bleeding or hemorrhages. But I didn't know that statistic, but that 95% of bleeding can be stopped with just applying direct pressure. And, when you say direct pressure, you're not thinking of the splinter you got and you're just putting your finger on it. I mean, if unfortunately, I hope this never happens, but if you were bleeding, I mean, I'm going to stick my knee or both of my palms on that.
Yeah. He gave us, and we used pressure bandages as well, Israeli bandages. And what's something called an H bandage, which is used by the Marine Corps. But it doesn't necessarily, you don't necessarily have to have those at your disposal. They're very easy to use. I think very worthwhile to have and to keep in your kit, your med kit.
Right.
But you don't necessarily have to have those. And we used, he used the example, right, of using the hand formation that you use when you perform CPR to get more pressure on the wound site, right?
Because think of how much pressure you use to do a compression of CPR. That's a lot of your body weight going into that.
And especially for something like a leg where the wound may be deeper, may be harder to get to with all the muscle, that extra pressure you can develop with that hand formation, I think is important.
But the use of like an Israeli bandage, which is a pressure bandage, I mean, in a scenario where you need to leave that person and go help someone else, or you need to assess the rest of them to make sure everything else is okay with them, that would be important and be able to use in a situation like that.
Yeah. So having at least one or multiple pressure bandages may help you triage the scene and help additional people, right? So the one great thing about the class, from my perspective, and I want to get your thoughts here, is that a lot of it was lecture, where Greg Ellifritz stood up and spoke to us and talked to us about how to carry out these protocols. But a lot of it was hands-on too, right? We got to use the different types of pressure bandages. We practiced applying them to others and also to ourselves, which was not so easy or as easy as it looked. And, we learned some techniques that are good for both, right? To apply these sorts of techniques to others and to ourselves. You want to say a little bit about that, the benefit of the practical exercises?
I think for a lot of people, especially me included, I need to learn by doing. So, I love learning about how this can help, how you can help people using all of this. And, him showing you step by step and showing pictures, but I need to do it. So I know how to do it. Yeah. So to me, that was quite helpful to be able to practice on myself and you.
Yeah. So it was very beneficial in terms of learning the skill and the technique, but it was also nice because we got to experiment with the different products, to the different types of pressure bandages, the different types of tourniquets, et cetera, so that, because a lot of what you read online it's useful, can be useful, but it can lead you down a rabbit hole that maybe is not worthwhile. And he had a lot of the most popular products there so that we could try them, because let's talk about tourniquets for a minute. In terms of applying the tourniquets, there were, the most popular one, the cat tourniquet, and then the soft T, which is another popular. The soft T, was easy to apply to someone else, but much more difficult to apply to yourself, right? So there was that benefit too of going through those exercises.
Yeah, not that I didn't trust Greg when he said that, but it was nice to be able to attempt it on yourself and be like, that's what he meant. That was really difficult to tighten that on my own arm.
Yeah. So we talked about applying direct pressure. We talked a little bit about tourniquets. And like I said, we're not going to get into a lot of the details here. We really encourage you to take the class or one like it. But stopping massive bleeding accounts for, what did we learn? 60% of preventable battlefield injuries. So this is a huge component, this M part of the March acronym. And so we spent quite a bit of time on this, and it included other things, right? Like packing wounds.
Yeah.
You want to say a little bit about that?
Yes.
So what types of wounds might you pack versus tourniquet? You want to,
So
from that perspective?
yeah. So basically, if you can pack it and you stop the bleeding, you're good. If you have not stopped the bleeding, then a tourniquet would be needed. And some things that seem kind of make sense after you learn it. You don't want to pack the chest or the abdomen, and you want to be very careful packing the neck just because of all the organs that are in those areas. If you've never seen arterial bleeding, as far as massive hemorrhage or bleeding goes, it's pretty crazy. I encourage you to YouTube it just so you know what it looks like, but it can squirt, like it's spurting blood. And those are things, most likely if it seems arterial, like if it's spurting blood and it's coming out in a huge amount, a tourniquet would most likely be needed. But if it seems really deep, probably packing on the extremity, as long as you can stop the bleeding that way.
So when we're talking about stopping bleeding here, we're talking about extremities.
Yes.
Really.
Yeah.
Because if you've got an arterial bleed or a bleed in the core, right? I mean, there's not much you can do with that, because the problem with packing those, right, and correct me if I'm wrong, is that the blood doesn't have anywhere to go, and it just fills your chest cavity with blood. So there's not much you can do there if you're going to bleed out from the core, the chest. The other thing about, and he spent a good deal of time talking about this, is a few of the misconceptions about tourniquets. You want to say a little bit about that?
Yeah, that was interesting. I hate to admit it, but I thought that you always release the tourniquet every 15 to 20 minutes, and that is completely wrong.
Yeah.
You can leave it on for up to 2 hours with no injury occurring after removing the tourniquet, when hopefully you're at the hospital. So yeah, I mean, obviously you want it as tight as possible where you don't feel a pulse and get the bleeding to stop. But I thought that was very enlightening that you can leave it on and you don't want to take it off.
Right. And in fact,
and it actually can hinder and hurt the patient if you release it in a timely manner like that, where you have a set time where you do that.
Yeah. The tourniquet, a lot of people, the misconception is that if you leave it on too long, you're going to lose your limb. And like you said, that the safe amount of time is 2 hours. But he told a story about a soldier who was in the mountains, and they had to carry him out, and he didn't lose his limb after having had a tourniquet on for, it was like,
I think 17
hours. I wouldn't want to leave a tourniquet on that long.
I don't think I wanted to take that chance.
But if the alternative is to bleed out, leave it on. Leave it on for sure. He did talk a little bit about this technique where if you want to try to pack the wound, if the tourniquet's been on for 2 hours or nearly 2 hours, and you're still some way away from a hospital, there is some thought anyway that it might be beneficial to try to pack the wound and then release the tourniquet slowly. And if the pressure dressing or the wound, the gauze, the hemostatic gauze, stops the bleeding, then you can leave the tourniquet off. Right. But the downside to that is, you want to say a little bit about that?
I mean, the downside is that they could start bleeding again. Also, he said that the windlass, which, how would you describe that?
It's the device you use to tighten the
just
tourniquet.
to tighten it. But I mean, it looks like almost like a little flashlight or something that's attached to it. Those can break when you undo them. So if you don't have another tourniquet, I would just leave it on.
Yeah. If you don't have a spare, I think you certainly just leave it on, because it's interesting, right? The windlass, the most likely time for it to break is when you release the pressure.
Right. Yeah.
So that was something interesting that I.
And that's another thing too. If you do not have a manufactured tourniquet, we talked about getting creative and making your own tourniquet, but the fact is you always need a windlass, or your patient's going to bleed out.
And that's why another misconception about tourniquets, belts are not tourniquets, and they make terrible devices to stop serious bleeding, because you can't use a windlass with a belt, right? That's the main problem with belts. So that's a common misconception, is people think they can tighten down a belt enough to stop the bleeding, and you just can't. But we had to practice, right, with tourniquets, applying them and making sure you had enough pressure to stop the pulse. And you would check your pulse down behind the thumb and your wrist, right?
So it's your radial pulse.
Check your radial pulse, and our pulse would stop. I mean, they worked.
Yeah.
So that was an interesting exercise. The last thing I want to talk about, I think, unless you have something else you want to mention about massive bleeding or massive hemorrhage, is the hemostatic dressings. We've alluded to those, and a lot of people think of like a Celox or a Quick Clot, which is a powder that people used to use to stop bleeding. But now the recommendation is to use, it's actually like a gauze, that is basically, it has the hemostatic agent in it, right? You want to talk a little bit about those hemostatic dressings and
so
how do we use those?
Right. So basically anymore, you don't want to put the Quick Clot powder in a wound. You would want to use the gauze that has the Quick Clot agent in it. So I mean, you would pack it in that gauze that has the agent kind of infused in the gauze. That should hopefully help stop the bleeding in 2 to 3 minutes, I believe. And you would still want to apply pressure, but that is one way that you could use those things instead of doing tourniquets and seeing if that helped stop the bleeding.
But the other thing is, I mean, time is of the essence, right? So if it's a massive bleed, you may want to go to the tourniquet. I would
suggest, if you're not sure, tourniquets.
And that was a huge component of the tourniquet, because some tourniquets were incredibly difficult to put on, especially on yourself. And the cat tourniquet and the softie, even applying it to yourself, you could get on relatively quickly. But some, I mean, 30, 40 plus seconds. And you really don't want that kind of time to pass, because those are valuable seconds and valuable blood lost.
I mean, and honestly, if you're putting it on yourself, if you're bleeding out, you're not going to be of sound mind after a minute of losing blood. So
the other thing I thought was at least beneficial for me, maybe not as much so for you, is the amount of hemostatic dressing or gauze that it took to pack a wound, or even a relatively small wound. If you have a wound that's like half the size of your finger, or maybe the full size of your index finger, it took like 2 feet of gauze to fill that wound. So if you've got a much larger wound, it's going to take a lot of that dressing. So one technique that I thought was interesting was, because a lot of people don't have a bunch of this hemostatic dressing. So if you don't have enough, you should use it first, right, to get to the source of the bleeding, and then fill in with regular gauze behind it, right? So I thought that was a useful technique. All right, anything else you want to mention or that you thought was interesting about the massive bleeding portion? I thought this, we spent a ton of time on this. Like I said, we're just going over the highlights here. But anything else you think you want to mention before we move on to airways?
No, I think we about covered it.
Okay. So once again, we're coming back to our acronym, the MARCH acronym, and we're primarily focusing on the MAR, the massive bleeding, the airway, and the respiration, because that is going to resolve over 90%, right,
Mhm.
of
Right.
preventable battlefield deaths. So the second one is airway. And you want to talk about airway just a little bit and
Sure.
what some of the prevention measures or treatment measures are there?
Yeah, so anytime if you come up on someone, you want to make sure that they're breathing. How do you do that? You can see if they have chest rise there. You stick your head down to their face and see if you can hear and feel breath. If you don't, the first thing you definitely want to do is thrust their jaw back and up so that they can get a better breath if that's the issue. There are a lot of different things we discussed about how to improvise for an airway. Probably the most interesting and terrifying one is
The nasopharyngeal airway.
Well, I was getting to that one,
Yeah.
but my goodness.
I have quite a few written notes here, so let me see.
Where you stick their tongue to their lip.
Right. They're the safety pins.
Yes. Yeah.
Basically.
Okay. Yeah. Safety pin.
Because the tongue will occlude the airway at the back of the mouth, and so you have to get the tongue out of the way.
Mm-hmm.
And there are these safety pins. This is actually an interesting, I think, distinction, if I recall correctly, between the wilderness survival technique and the tactical combat casualty care technique. Was that the wilderness technique still recommends the use of the safety pin to attach the tongue to the bottom lip so that the tongue won't occlude that airway. Is that, am I recalling that correctly?
Yeah, that's right. Okay. And it sounds crazy, but I mean, if you had to do that when you have several people down, what are they going to be more mad at you about? That you safety pin their tongue to their lip, or that they can no longer breathe? Some other things are a nasopharyngeal airway, which is basically just a very small tube that you can put in someone's nostril, and it goes down the back of their throat to help improvise and get that air out. If for some reason there was something occluding their breathing that you were unaware of. There's intubation, but that's not really something that you're going to want to be performing. There's also the cricoid thyrotomy, and really, unless you feel very confident in doing that, I would probably steer clear of that one as well. But there are things that you could learn to help with the airway.
And the nasopharyngeal airway, the tube that we talked about that goes through the nostril. This was interesting too. You actually go basically straight into the face rather than up the nostril toward the brain. But the main concern with those was we don't want to use those if we're concerned that the person has a basal, am I saying this correctly? A basal skull fracture, which, can you talk about that?
Yeah, so that is obviously a fracture of your skull, but it's in a way that if they had that type of fracture and you were inserting something towards the back of, the back of their nose, you could actually hit their brain doing that, and obviously cause much more damage than you intended.
Or force bone fragment back into
Yes, exactly. Yeah. And so just real quick, some things to watch for a basal skull fracture would be what you call raccoon eyes. So bruising under their eyes. They could sometimes get bruising behind their ears. They might have what you would think is a runny nose, but it's going to be kind of this thick, kind of viscous white runny nose, and that can be your cerebrospinal fluid. And so those are all things to just be aware of if somebody has that going on, that you would not want to use a nasopharyngeal airway.
Yeah. The other thing I think was important about the airway portion of the class 2 was the recovery position. So you mentioned
Yes. Yeah.
raising the chin to open up the airway, making sure the tongue is not occluding the back of the mouth, and the nasopharyngeal airway as a possibility. But the other thing is making sure the person is in the optimal position to breathe too, right?
Yeah, that's important.
We can't really demonstrate by podcast, but basically you're turning the person on their side with their top leg slightly forward to support them so that they are in a position where their tongue is not going to the back of their mouth and they can get good breathing.
And this has nothing to do really with a little bit, but if someone were having a seizure, if you came upon that, that's the position you would want to get them in as well.
Yeah. And one thing that I was looking through my notes here, and I think is important that we've skipped over a little bit with the tourniquet, is where you place the tourniquet, because there are a few different theories about this, really two. Is do you place it as high on the limb as possible, or do you place it basically just a couple of inches above the wound? You want to say something about that or explain that? Those two theories?
Yeah. So the issue with placing it a little bit higher than the wound is that if a limb was severed, that artery can kind of recoil back. And so you may be placing it above where, the trauma occurred, but that might not be where the artery is at anymore. I mean, it may be even higher than that, or just right at that.
Or you may have bullet fragments, for instance,
exactly,
that have lodged themselves even further and caused
even more issue. Yeah. So what Greg encouraged, and what sounds correct to me, is putting it as high on your extremity or your patient's extremity as possible.
Yeah, so it's basically going to cut off blood flow to the entire extremity. Yeah, so I think that's certainly the safest bet.
Yeah.
Okay, so we've talked about massive bleeding. We've talked about the highlights of the airway, and just knowing the skills and techniques for these two portions, it covers 66% of preventable battlefield deaths. The third one, and the one that gets us to over 90% of preventable battlefield deaths, is the R, the respiration and breathing. And the primary portion of this one is the tension pneumothorax. You want to talk a little bit about that?
Yeah, sure. So a pneumothorax is basically where you have air escaping the lung and starting to build in your thoracic cavity. A tension, and so people can get those spontaneously. You can have those in people who have lung issues like COPD or asthma. They're more prone to those types of things. If you're a smoker and you cough really hard, that can cause a pneumothorax. The difference is a tension pneumothorax is when that air starts to build up and basically cause tension in that chest cavity. So that can happen if you have a penetrating chest wound, if even in a blast situation, or say a car wreck, if you just had direct trauma to your chest wall. And when you say chest wall, you mean your front or your back where your lungs sit. If you are in a car wreck and you get an injury to your chest wall, that could cause a pneumothorax, but then that air is building up and it's causing tension. So some things to watch for if you thought maybe someone had a tension pneumothorax would be, obviously, they're going to tell you they can't breathe, and they'll probably start having pain on that side. And something else is they'll have what's called JVD, which is jugular vein distension, which is just in your neck. And basically your veins your arteries pull your blood away from you, arteries away, veins send it back to your heart. But if that has so much tension in your heart, you can't get that blood back. And so it's backing up in your veins, in your neck. You can also have tracheal deviation. So let's say I had a tension pneumothorax on this side of my body, my trachea would start to deviate towards Alex because all of that tension and all that air is building up on this side. So it would go that way.
The onset of this is not going to be quick, more than likely, right?
No.
I mean, it's going to take some time
mm-hmm.
for this tension to develop in the
mm-hmm.
in the cavity,
yeah.
the chest cavity.
And we're not saying 5 minutes or even 10 minutes. It could be a half hour, but you would probably start seeing some of those symptoms.
Right. And so the person may seem to be breathing
mm-hmm.
okay at first, but then
as that air builds up in their chest, that's not escaping anywhere.
Right.
Mm-hmm.
So they'll continue to struggle more and more with their breathing. So that's a very good sign
mm-hmm.
that this TP, this tension pneumothorax,
mm-hmm.
is occurring. So there are a few things. So this is, like you said, caused by a hole, a penetrating chest wound, typically. And so the air comes in, but it can't escape.
Right.
So there are a few things we can do to relieve that, right? There's what are called chest seals that we can use, right?
So if it's a tension pneumothorax, it's not going to relieve that, but
it will prevent it. Yes. Or at least slow it down. But there's also a needle decompression. You want to talk a little bit about how that works?
Yeah. So basically, there are instruments you can buy. I think you can buy them online. And again, kind of like the cricothyrotomy technique and procedure, if you're not sure, you may just want to wait till EMS arrives to perform that one. But you have a needle that has a small tube on it, and you can go from the side or you can go from the front. But you basically insert it and remove the needle, and then they have that tube still there so that air has a way to escape.
Yeah. So it basically acts as a vent for the chest cavity to allow air to escape.
Right.
And we talked about chest seals, but those aren't necessarily going to stop this from happening. You can use gauze that's been covered with Vaseline, basically, as a chest seal. They also make specific chest seals that allow air to escape but not come in. So those are things you can consider if you're concerned about this or want to keep those sorts of products in your
And I should mention
kit.
Greg, because Greg mentioned this, the Good Samaritan law, it doesn't sound like it covers needle decompression and kind of more intricate procedures like that. So you may want to see what your laws say in your state, because you also want to keep yourself safe. But obviously you want to help other people, but you need to know what you're doing.
Yeah, especially if it's a family member and there's no other option.
Right.
This might be something
of course.
you consider.
Or, I mean, if you're in the back country, if that's what you got to do, that's what you got to do.
But the first rule of thumb always is do no harm, right?
Yes, so, exactly.
If you're not comfortable with it, certainly
don't go inserting needles or cutting on people.
Because the danger, right, is that where you have to insert the needle, you could hit the heart or the heart muscle and cause a much greater problem.
And there are veins and arteries and nerves along every rib, and so if you don't get it right, you could cause injury that way too. Obviously the heart is much more important, but you can cause injury that way as well.
There was a technique, and I'm blanking on it now, but it was basically burping the tension pneumothorax. Do you remember what that was? So
it was when the patient exhaled, you would open the chest seal and let that air kind of escape, and then when they inhaled again, you would put it back on there.
Yeah, and this is something that you would have to repeat quite a bit for it to be effective. But if you don't have a needle or are not comfortable with using the needle, it may be a substitute or alternative technique. Right. Okay, so we've talked about massive bleeding, airway, and respiration. Those are the three big ones, the ones that cover over 90% of preventable battlefield deaths. I think actually 99%. So the C and the H are, the problem with those is they're not really preventable battlefield deaths. You want to say a little something about the C and the H? I know the C is circulation and the H is we talked about head trauma too. And then hypothermia was also one. But hypothermia is pretty obvious. It's warm the person up.
Warm them up.
So you must say a little bit about circulation.
Yeah, so circulation, and head trauma. Unfortunately, if, someone has a massive wound to their chest or even their belly, that's going to impair circulation, and there's not a whole lot you're going to do to save them, unfortunately, and really just help them get as comfortable as possible. You can apply some pressure, but unfortunately, they're most likely not going to survive that.
Yeah. So we really didn't talk about that much in the class because that's not really a preventable or a very small percentage of the preventable deaths. So anyway, the MAR
and head trauma too. You're not going to have a CT scanner or MRI machine on site to know exactly what's going on. There are things you can do. You can check their pupils, things like that, but that's not going to help fix them. You can make sure they're staying stable, but in a head injury, there's not much you can do on site for that sort of thing.
The other thing we talked about, and this isn't really the tactical combat casualty care protocol, but we talked about other things that I think people would find of interest, just with respect to wound cleaning, for instance, or things you might consider if you travel in places that don't have advanced medicine. And I think there were a few good tips and pointers with respect to those things. You want to say a little bit about some of those?
Yeah. So I know I always tell my patients, and we talked about it in the class, you have a lot of people, and probably before PA school, I would have told people to do this as well. They always want to use hydrogen peroxide on a wound over and over and over again. And that is actually incorrect. Alcohol and hydrogen peroxide. I think Greg said not to use it at all. I usually tell people you can use it the first time to really clean it out. And he may have said that. Okay. But after that, it really can cause skin breakdown and not healing. So our goal is to have the wound be healing. But if you are pouring those substances on that or applying them, that's just going to cause skin breakdown, and they are going to take forever to heal. Yeah,
it'll really inhibit the healing process. So we talked about rinsing the wound, right, with water, and basically the rule of thumb is that as long as you can drink it, it's safe to rinse the wound with that water. If you're in a location where you're not sure if the water is clean, it may be helpful to have water purification tablets. But that's really the key, is before you close up a wound, you want to make sure you've cleaned it out thoroughly.
Right.
And I can't remember the rule of thumb. Was it a quart per inch?
I think it was a quart. It was something crazy.
It's in my notes, but I don't have it handy here. I think it was 1 quart of water per inch of wound.
Yeah, that's a massive amount of water.
But you want to make sure you rinse it out thoroughly before you close it up, either with, and we talked a lot about this too, how to close up wounds. If you don't have stitches, you can use steri strips or butterfly strips. I guess that's what they're called. Super glue. We talked about the uses, different types of super glue, even non-medical super glue. And we talked about stitches and staples. I mean, these are things that you can get. And he talked about how to acquire these sorts of things if you're interested in learning.
And really,
wound closing techniques.
If you don't want to do those steri strips, can really have an impact on closing up a wound. So if you're just totally against, you never want to learn how to do suturing, steri strips, I would encourage you to get and really learn how to close a wound up well with those, because that can make a huge difference.
Yeah. So we talked a lot about that actually, is wound closure and cleaning. We also talked quite a bit about how to acquire medications, if you have medications that you just have to have, and you know how to acquire those if you're traveling in particular, or if you want to have some amount for preparedness reasons,
as he called it, if a zombie apocalypse. Okay.
And he was talking, and these were all legal methods, by the way, that he was talking about how to acquire these. So we kind of breezed through those things a little bit, and it wasn't, that wasn't our primary interest in the class, but if that is something that's of interest to you, I think it's another.
He talks a lot about it in the class, and we would encourage you to take it.
Yeah, exactly. And then we didn't talk about this too much, but got a lot of ideas about sort of assembling your own medical kit. And I think the important part is that you need to have it handy, or if that's on your person or in a backpack or a fanny pack or in your car, it needs to be handy, because if you don't have it, like a firearm, when you need it, it doesn't do you any good.
Right.
Yeah. So, so anyway, I think that's where we'll wrap it up. I learned a lot. I think you did too. Maybe not as much as I did, but we learned a lot and really enjoyed the class.
And I would just like to say too, we're not telling you all of this to scare you in any way. I think it's more scary if you don't know what to do. And we can all hope that a situation never arises for ourselves or for people we love or even strangers, and we would never have to use these skills. But it makes me feel better that I know what to do in case that ever happened, that I would be able to hopefully help someone if I ever needed to.
And before we close up here, I'm going to pull up my notes. I think we've got, or I can pull up his website, and I said I'd link to this in the show notes. I was going to mention the 2 classes that are offered the rest of the year. Bear with me here just a moment.
Yeah, and I will say too about Greg, he's a great teacher. He keeps you engaged during the whole class. He's funny, but it keeps you on the straight and narrow a little bit. So, I mean, I loved it. It was wonderful. I feel like I learned a ton.
So certainly for me as a non-medical person, a layman in the medical realm, it was very interesting, learned a lot. But even for a medical professional, it's certainly very interesting and still very worthwhile.
But I love that kind of stuff. Yeah. But I loved it, and I would highly recommend it.
The classes, I just got it pulled up here. The class is offered again August 19th in Delaware, Ohio, which is just north of Columbus, Ohio. And then again, October 15th, Yadkinville, North Carolina. So check out those classes. I'll link to it in the show notes. Whitney, thanks for joining the show.
Thanks for having me.
Yeah, I enjoyed it. I hope our listeners did too. If you did, help us out, spread the message of freedom and preparedness, and like and subscribe to the show to help us spread that message. So thanks everybody for tuning in. Tomorrow for Monday Gun Day, I'll be back in the studio with Mike Ooley to discuss maintaining safety at the scene of a self-defense incident. So make sure to tune in for that. And until next time, remember, you are the Forge of Freedom.
Thanks for listening to this episode of Forge of Freedom. Be sure to subscribe wherever you heard this podcast so you never miss a future episode. For more information or to connect with Alex, you can go to forgeoffreedom.com or follow him on Twitter at Forge of Freedom. Until next time, remember, you are the Forge of Freedom.